Welcome to Cardiocast. I'm Dr. Jim Dwyer. Today we begin with news of our own. This is the final episode of Cardiocast. Thank you for making Cardiocast and Card Talk a part of your week. And as a reminder, you can catch all the latest news in cardiology at our website at www.mdedge.com/cardiology. This week we're featuring top stories from the American Heart Association meeting in November, from ischemia to DAPA-HF and marijuana's connection to dangerous arrhythmias. And now the news. The ischemia trial compared invasive versus conservative management for patients with stable ischemic heart disease. And the response to its findings at the AHA meeting was emphatic. Ischemia is practice-changing. Ischemia included more than 5,000 patients with moderate or severe ischemia. Study chair Dr. Judith Hochman of New York University reported the results. They showed that an initial invasive strategy plus optimal medical therapy did not top optimal medical therapy alone at reducing the risk of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The composite endpoint rates at 4 years were 15% with the conservative strategy and 13% with the invasive strategy. Nor was there a significant difference in the major secondary endpoint of cardiovascular death or MI, 14% with the conservative strategy and 12% with invasive management. And to the investigators' surprise, patients with more severe ischemia or more extensive multivessel involvement did not do better with the invasive approach. In patients who had had angina at least once a month, an invasive strategy did deliver significantly better angina control and quality of life than optimal medical therapy. But an invasive approach gave no quality of life advantage in patients who reported no angina within the past month at baseline. Dr. Alice Jacobs is the director of the Cardiac Catheterization Lab and Interventional Cardiology at Boston Medical Center. Given the findings, Dr. Jacobs says she'd feel comfortable advising patients without angina or with controlled or tolerated angina not to undergo an invasive strategy. The practice-changing DAPA-HF trial gave strong evidence that the diabetes drug Dapagliflozin cut cardiovascular death and acute exacerbations in patients with heart failure with reduced ejection fraction, even among those without type 2 diabetes. But a new analysis of the 55% of the trial's patients who did not have diabetes should seal the deal. Dr. John McMurray says the relative and absolute reductions in cardiovascular death and hospitalizations or urgent visits for heart failure were substantial and clinically important, and those benefits were consistent in patients with or without type 2 diabetes. Speaking at the AHA meeting, Dr. McMurray of the University of Glasgow outlined the primary findings from the patients without diabetes. In short, those with a normal hemoglobin A1C level at or below 5.6% had a 26% relative reduction in the study's primary endpoint. That's essentially the same response as the 28% relative reduction in events in patients with type 2 diabetes. Dr. Larry A. Allen of the University of Colorado was the designated discussant for the trial. He discussed the strength of the findings in an interview.
This is a particularly strong subgroup analysis, and the reason for that is that the investigators, when they designed the trial, they had this question in mind. So they really went out and got a population of more than 4,000 patients, and again, about half of them had diabetes and half of them did not. So rather than a very small subgroup, you're really looking at a large trial that has two large subpopulations. The other is that because this was a central question, when they randomized patients, they stratified that randomization by the presence or absence of diabetes. So I don't think this is kind of a post hoc look at an interesting finding that somebody dredged up. This is a hypothesis that the investigators put out from the beginning, and I think that these are very strong findings, and the statistical significance of the benefits in terms of the outcomes, even in the subgroup of non-diabetics, is very strong.
We'll be right back after this message. A relatively affordable gout drug may deliver what a pricey biologic agent has already demonstrated: protection against cardiovascular events after a heart attack. The Colchicine study included more than 4,700 post-MI patients. Researchers at the Montreal Heart Institute presented the study's findings at the American Heart Association scientific sessions. The oral anti-inflammatory Colchicine significantly cut cardiovascular disease events by 23% compared with placebo. Colchicine was combined with a post-MI regimen of aspirin, a second antiplatelet drug, a statin, and in many patients a beta-blocking drug. Colchicine's performance appears to replicate that of a relatively expensive monoclonal antibody, canakinumab. In the earlier CANTOS trial, a canakinumab injection every 3 months led to a 15% drop in cardiovascular event incidence compared with placebo. Young, frequent marijuana users who also smoke cigarettes are at a nearly 3-fold increased risk for stroke, and people with cannabis use disorder are at a 50% greater risk of being hospitalized for arrhythmias. That's according to new research to be presented at the upcoming American Heart Association Scientific Sessions 2019. Researchers at George Mason University in Fairfax, Virginia, analyzed data on nearly 44,000 survey participants. Among the nearly 14% who reported using marijuana within the last 30 days, the odds ratio for young-onset stroke was 2.75 compared with non-users. In a separate study, researchers at Griffin Memorial Hospital in Norman, Oklahoma, found that people diagnosed with cannabis use disorder were up to 52% more likely to be hospitalized for an arrhythmia. Given the findings, the researchers recommend asking about cannabis usage in patients who present with symptomatic arrhythmia. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. Cardiocast Cardiology News and MDedge Cardiology are edited by Catherine Hackett. For MDedge, I'm Dr. Jim Dwyer. Have a Happy New Year, and thanks for supporting Cardiocast.